Okay, it's 2 minutes after the hour, so we'll get started. Hello, everyone. I am Diane Obey, and I am with the Alberta Spore Support Unit. Some of you may have seen me already. Sorry about that. And before we get started, I'd just like to say that even though we're meeting virtually, we are all living on the traditional lands of the Métis, First Nations, and Inuit. And I acknowledge that I'm living and working on and I'm privileged to be here on Treaty 6 territory. And if you can all take a moment to think about where we are living and what we've learned from the traditions and cultures of the First Nations, Métis, and Inuit people. Couple of housekeeping things. If you want to put your speaker view on rather than gallery view, that'll allow you just to see the speaker and it's a little easier to follow. And please turn your video off. That helps with streaming and also protects your privacy. This is being recorded. And also, if you have any technical difficulties, the first thing to try is to leave and come back again, because that magically works sometimes for whatever reason. Otherwise, Amanda Wagner is here helping out as well today, and she is on chat and the chat and Q&A in Whova, or you can post your questions or concerns in the chat in the Zoom, the actual Zoom. So if you experience any technical difficulties, she'll try to help you out. So we will have a couple of polls, and our speaker today, Eddie Lang, will point to them when it's time. So my job right now is to introduce Dr. Lang. And he said to be short and sweet. So he's a professor and department head for emergency medicine at Cummings School of Medicine, University of Calgary, and Alberta Health Services, Calgary Zone. So he is very much interested in knowledge translation and evidence-based medicine and operations research. So I expect he's a convert to patient-oriented research because of that. So happy to have you start, Dr. Lang.
Thank you so much, Diane, and it's such a pleasure to be here. Big thank you to the Alberta Spore Support Unit for inviting me to give this talk. It's really exciting to have this opportunity. We're going to be talking about the Builder program. You may have seen it advertised as Physician Builder, but I've been corrected as we've done some preparation towards this session. This is not just for physicians. Really, these could be anyone with a clinical background who's involved in the Builder program. And we're going to spend a fair bit of time explaining it, but it's of course an essential part of the Connect Care implementation and helps open the door to the opportunities that lie within for research quality improvement and patient-oriented research. So I'm going to first start by letting you know that I've brought some friends with me. One of the key features of Connect Care governance and the research portfolio is something called the Clinical Inquiry and Research Working Group, CIRWG. That's co-chaired by Dr. Nish Panu, who's my equivalent scientific director with the Kidney SCN. I'm with the Emergency SCN. And she chairs that with Marc Leduc. I'm her backup chair. I'll be presenting for about 20-25 minutes on the Clinician Builder program, and then I'm going to pass the baton to Pavel Medvedev, who is in clinical informatics and manages the Clinical Builder program. And so you'll be hearing more from him before we open it up for Q&A. Thanks as well to the other members of the CIRWG who've joined. Trina Johnson is the provincial lead, Health Evidence and Innovation Clinical Service Excellence lead. And Dr. Vince Danino is co-chair of the Clinical Builder Committee, Physician Master Builder, South Zone. That'll all start to make sense once you hear a little bit more about the program. And will all be available for the Q&A and hopefully can answer your questions. So I think I'm going to turn things over to, let me first explain my disclosures. I do not have a remunerated Connect Care role. I did receive travel support to go to Verona, Wisconsin and do 2 builder training sessions. And through my interest and involvement, I'm with the Emergency Department Physician Working Group on Connect Care, as well as the Builder Working Group, but I do not have any formal training in medical informatics. So please, any overly technical questions, I don't think I can help you with. So big picture, I'm going to hope you leave this session with a really good understanding of the Builder program, but more importantly, what is the role in the QI improvement and research agenda for the Builder program in Alberta? And have you thinking about ways that a builder can help facilitate your projects and your interests in Connect Care. And there's incredible amount of things to talk about. I don't think we'll manage to get through everything, even if we've devoted a lot of time to the Q&A. So please feel free to reach out to the people that I've identified so far and myself if you want to continue the conversation. We're certainly open to that. So we're gonna check in on getting to know you and where you stand in terms of Builder and doing research and QI and analytics within Connect Care. And over to Amanda for the Mentimeter poll.
Great. The poll should be linked into either the Whova app or the Zoom chat. So if you want to take a minute and fill that out, I believe Diane can see the results for that.
It's in the Whova chat and the Zoom chat. We have links.
Okay, we're giving you some time to fill that in. I'm having, let's see, okay, where is it? Whoops.
We're getting a few in. Let's give it another 10 seconds.
And there's a note in Zoom from Tatiana that there's no familiarity with the Builder program.
Thank you. Okay, so we have 3 people who filled out the poll, said they have some familiarity. One who's worked with or is a builder. 2 who have little or no familiarity, and 1 who says none of the above, but I'm keen to learn more about the potential. So I think you've got some familiarity to, well, we get somebody else saying little or no. So I think to get us all on the same page, you want to start from scratch.
All right, well, that's great. And that's perfect, actually, because this is a kind of an entry-level talk about the Builder program. And hopefully we'll be able to generate some interest and some excitement. I presume you're still seeing my slide. Is that okay? Are you seeing this now? What is a builder?
Yes.
Okay, great. Well, so this is the Physician Builder page from the Epic user web. So once you become registered with Epic and start being an Epic user, you can have your own account and your own space within the Epic user web, which is just a phenomenal mountain of resources, including something that I'll point to here called the Community Library, where hundreds of hospitals and organizations that use Epic for healthcare share information and share resources, which can certainly be extremely helpful. This is the Physician Builder page, and it's where people who are physician builders contribute questions and resources and share in this forum. The main thing to bring to your attention, though, and Pavel will elaborate on this, whoops, is that according to the Epic view of things, is that a clinician is someone who takes responsibility for prioritizing issues, making content changes, and disseminating information to their department. So, as many of you are moving towards Connect Care, either from a research capacity or as providers, certainly that will resonate with you, I hope, and that you'll be able to want to meet a builder and work with builders to achieve that goal. So here's a cool thing. When you work as a physician builder, you log into something called Hyperspace, which is the Epic information platform. And as a builder, once you've been certified, and I'll explain that in a minute, you access these builder tools. This is your library of builder tools. And recently I've been helping with a therapy plan for oral outpatient antibiotics that would be initiated in the emergency department, but then would follow up in the OPAT clinic or a medical day hospital. So what I do is I bring up my therapy protocol builder and I start building using information on appointments and medications and frequency. So I can build a therapy protocol that is then going to be hopefully of use to many, many colleagues. And just a little bit of technical thing. When I initially start working in Builder, and there's, as you can see here, there's so many different things that you can use that you'll certainly become familiar with as your system goes to Connect Care. I usually, just to give you an idea of how that works, I usually start in some place called Sandbox, which is appropriately termed a place where I'm just kind of playing around and doing some preliminary building that doesn't break anything. and Sandbox gets cleared every night at midnight. So I hope I won't invest too much in Sandbox because I lose it at the end of the day. Once everybody thinks they're happy with my building work in Sandbox, I go to point of proof of concept, which is POC. And once things are finalized in proof of concept, it goes to production. And once it's in production, anyone who's an Epic user in Alberta, a Connect Care user in Alberta, would be able to access the tools. So that's you know, you'll see a lot of correlation between Star Trek and Epic and Connect Care. This is kind of like, you know, me at the beginning of a Starship Enterprise, kind of a voyage into building for Connect Care, if you like that sci-fi analogy. So what we're talking about here is really transforming the model of how we do IT support. You know, you've all worked with some kind of an electronic system, and typically you're calling your IT people, you're putting in a ticket, and you're doing sometimes what feels like an interminable back and forth until your problem is solved, until something is created that meets your needs. And the concept behind the builder is that you will take someone who will have Connect Care skills, building skills, and also bring a clinical lens and perspective to whatever project you're working on. So it shortens that back and forth time, but builders generally don't work independently. They usually are in in a dyad relationship with an analyst to support the build. But it's like a clinical and an IT person working together on a particular project, and I'll elaborate on that in a minute. So here's the physician builder training. Of course, it's now gone virtual. There was a time when you would go to the Epic University campus in Verona, which is pretty an unbelievable place to see, and hopefully that will be something that you can do in the future. So when you do the builder training, you start with the basic course, which is known as CLN 150. And once you're completed the basic course, you need to do one advanced module to be certified as a builder. And there's a number of different options. There's just the general advanced course. There's something called Healthy Planet, which is, I think, will involve more population studies and something that I'll talk about in a minute called registries. I took I believe it was called CLN 161, which is electronic, which is about analytics. And I took that because of my research orientation. And the cool thing is that once you're done all your training, they give you a Leatherman tool because it's a building tool and it shows that you're a builder. And this is all done through the University of Wisconsin. And the builder courses are free as long as you can, I don't know if that's still the case now that it's all gone virtual, but it's the only thing would need to be supported for was travel and accommodations back before COVID hit. So here's some data I got off of the user web, a couple of slides showing what's happening now in the builder community. And here, I mean, this is good news. When questioned, are people using their builder skills to guide projects at your organization? Most of the people who've gone into building have continued to do so. And this is a bit more of a busy slide, but it will show you what kind of things builders do. And I can kind of run through this quickly because it's although I can happy to elaborate. What you can see based on the legend at the bottom is that the green thing is I have access and I build these tools. And as you'll soon find out, a lot of the terminology in Connect Care has to do with the word smart. There are smart forms, there are smart texts, there are smart, there are flow sheets that follow that model. And so what we see from this slide, from the builders that have been queried, and it looks like there's more than 600 that have responded to this survey, most are involved in smart forms, order sets, smart tools. A lot of them are doing BPAs. BPAs is best practice alert. So those of you who are on Sunrise or other systems knows that's kind of the idea. There is a form of clinical decision support or a pop-up window that guides your decisions, whether it be an allergy alert or directing you to some kind of more formal decision support for ordering a test or ordering a treatment. And as a builder, you learn how to create best practice alerts. You also learn how to do other things such as which are more on the analytic side, which involves dashboards and other kinds of reporting, workbench reports. One of the most commonly known and easy to use and most useful is something called Slicer Dicer, where you're basically creating tables where the columns and the rows are built to your specifications and can present visual data on whatever it is you're interested in. Unfortunately, there's not many people working on registries, but I think that's a very powerful tool. So for example, if you wanted to follow just data on all of the patients who come to the emergency department with a Tylenol overdose, for example. So you can create any kind of registry you want. It could be for patients who have a specific disease on their problem list or who have a certain abnormal blood test, example, a Tylenol, high Tylenol level. And a registry is something that you create which tracks data on that population of patients over time and has a huge research potential. So what can all this look like, this builder expertise integrated with the very research and innovation and QI focused future of Connect Care in Alberta? And I thought maybe the most straightforward way to do this is to provide a kind of a concrete example. And this is a bit visionary, and I'm sure not all this is immediately available. It's not so much for the rollout, maybe more for the optimization phase of Connect Care. But let's think about concussion. Let's think about the very common problem of people with head injuries, hitting their head and being diagnosed with concussion. How can a builder and Connect Care get involved to optimize concussion care? So this is not carved in stone, and it's not necessarily evidence-based, but I've just identified 4 problems or 4 areas that, from my perspective in the emergency department, often come up as issues in concussion care. So number 1, we're a little bit all over the map in who we tell you've had a concussion and not had a concussion. There's variability in applying those diagnostic criteria, and that's important because you don't want someone walking around with that concussion label if they didn't actually have a concussion. Number 2, we use way too much CT for these minor traumatic brain injuries, and that's a problem. Let's imagine we have been involved with this previously at the Foothills. Let's say we want to do a biomarker trial of concussion and use a biomarker. This is a true study where the biomarker will predict complications of concussion, namely post-concussion syndrome, which is a debilitating complication of concussion where you can't focus and can't concentrate. And then you have, and then I think another big problem is that we have is that patients who leave the emergency department don't have a really good way of looking after themselves and follow, and we have like quite variable approaches to connecting patients with their family doctors or other resources after they leave the emergency department. So what could we do with to get to better diagnoses? Well, with a builder, you can create a head injury order set where you would embed a smart form that would have very clear criteria for who really has a concussion. You can use the slicer dicer tool that I mentioned earlier to monitor compliance with form completion and then create an analytic dashboard to monitor your concussion care. That's for better diagnosis. What about for overuse of imaging? Well, you can embed clinical decision support. I'll describe that a little bit more in a minute. You can create a best practice alert to ensure that CT utilization is the most appropriate possible when a CT is ordered. And then you can create a documentation flow sheet that captures that if a CT is ordered, it was for the right clinical criteria in a patient with a brain injury. So here's something potentially very exciting in Connect Care. In emergency medicine, we have a highly validated clinical decision rule called the Canadian CT head rule. It's exquisitely sensitive, fairly specific, and it's been validated dozens of times. It's really the standard of care to determine appropriateness for CT head use. And it lives right now in many places, but you can find it in a website called MDCalc, which is a free access library of hundreds of decision support tools for a myriad of conditions. And of course, you know, as we're building our head injury order set, you can certainly link to this in Connect Care. There's going to be a hyperlink to the MDCalc order set, but the MDCalc application also lives in something called the Epic App Orchard. And with optimal integration, you can really take the level of sophistication far higher than a simple link that will take you out to the web and bring you to the Canadian CT head rule. You can imagine where the app is integrated in such a way that it's auto-populated and auto-calculates the head injury score for any patient coming to the emergency department for a head injury, and it can generate data that you can follow over time, and it could be integrated into the ordering of the CT so that you'd have to bypass or go around it if you were going to order a CT in someone who did not meet the head injury rule based on this Canadian CT head injury tool. So the App Orchard has hundreds, well, maybe not hundreds, but at least several dozen apps that could be integrated into the Connect Care system. There's probably a cost for that, but it's certainly quite exciting. What about clinical research? So, I mean, there's a number of ways to look at this. You can create a registry for concussion. You can, if you're doing the biomarker trial, you can develop within the research module in Connect Care a way of recruiting and monitoring patients that have consented to be into the study. You can get patient consent at the moment of arrival in the emergency department or through or through the myhealth.alberta interface potentially, so that you can know that if they had a concussion, they would be agreeable to enrolling into a study. And then through a tool, I think this is possible, I mean, it may not be through a common EPIC rule, but we can also think of facilitating randomized, controlled, or pragmatic trials. A common EPIC rule is a way to establish some way of separating out patients into two groups, and or setting some other kind of logic rule that would mean that one patient gets treatment A and one patient gets treatment B, or one physician sees order set A or one physician sets order set B. And I think the gold standard for how Connect Care is doing this is exemplified in a trial that's nearly completed now in Ottawa, that's also on the EPIC system, where 8,000 people are being randomized to receive either female source blood for a blood transfusion or male source blood for a blood transfusion. Apparently, there's a clinical controversy as to which one might have better outcomes, and they are doing this study with an exemption from ethics, so that they can simply automatically enroll patients into this pragmatic trial automatically without formally seeking consent. And this is called the ITADS trial, ITADS. I'm going to put the link to the clinicaltrials.gov page on this in the chat window. So the last problem we have is more patient-centered care. So let's imagine this. There are a number of really good concussion apps out there. I'm currently working with the Neuro Rehab and Vision SCN on one of those. And imagine if a validated AHS-endorsed concussion app was in the patient portal, myhealth.alberta.ca. It could facilitate symptom tracking, collecting history. It could, in theory, link up with the sports med clinic or a neuro clinic to follow the patient's progress. It could facilitate better navigation to the AHS clinic that's best suited for that particular kind of concussion. And it could allow us, based on the patient's risk of a post-concussion syndrome and other features, allow a much more tailored, personalized discharge instruction and direction to self-management tools that would be readily available within the Connect Care interface. So this is a bit visionary. I mean, we don't have this yet, but these are certainly things that would be possible in Connect Care and can be built in Connect Care. So I'll leave you with this quote from Dr. Lurie at the Children's Hospital in Philadelphia, who emphasizes the importance of the builder in many different governance areas, including clinical decision support. There's certainly opportunities in building useful tools for care and improving flow and the patient experience and patient engagement. So knowing what the capabilities within Epic as builders, I think really has helped us be in a much more advanced place. So a little pitch for the builder program. So I am going to pass the baton. I believe we've got Pavel on the phone, or on the Zoom session as well, who's going to give you a more detailed and shorter presentation on the Physician Builder program. So I've relinquished control. I'm no longer I've stopped sharing. Pavel, are you coming on board to present your slides?
Yes. They should be coming up shortly, and I'll keep myself to about 10 minutes. Feel free to cut me off at any point to let me know if I need to speed that up or slow down.
You're perfect, Pavel, and we see your slides. Go ahead.
Excellent. So Eddie, thanks once again for having us joining you today in this discussion. It's having been involved with the building of the Builder program for the last few years. It's really exciting to see how some of the concept we've laid down, some of the foundations we've established of having this organic community grow, and having presentations like this where folks are talking about what is the art of the possible, what can we do with the system given this opportunities that we have provincially with a single record, a single system. It's very exciting to see this come out and grow organically. So my goal today is really just at a high level to speak a little bit about the Connect Care Builder program. What are we doing as a program? What's our role? I'll be very brief about the existing builder roles and some of the volumes we have. Focus a bit on the governance as we talk about customizing the system and developing new tools. We do have to make some considerations about the provincial concept, the principles of Connect Care, reducing unhelpful variation, and then finish off with some of the opportunities and specifics of how people can get involved. So at its core, the Builder program is there to establish the understandings, tools, processes, and relationships to help facilitate this interest, this desire, and that people might have of an ability to influence how the system behaves, influence on questions we might want to answer as a learning healthcare organization, and give folks the right tools and workflows to be able to do that. I'll make bold statements of, gone are the days of when we might have something that people want to change and there is no clear process on how to get involved. So what we're doing is a builder program that's being endorsed by the triad of the Connect Care project, CMIO office, clinical operations, and of course our IT colleagues, is that if there's a desire for people to get the training that they need, there's a desire to make their time and scholarly commitments to make this a certain impact, the program is there to make sure that we'll establish the right workflows and processes to help people get that work done. Eddie, you've talked about great examples of some of the benefits, and Epic through the user reps has a ton of information from other organizations that we've been really working closely with Epic, and in fact are maybe moving into the direction of being an organization that's setting some of the standards on how builder programs can form. We were definitely their first customer, their first client to establish a builder program. Prior to launch, we were able to have builders involved in our Wave 1 launch and continue to do so throughout the different waves. And our volumes of builders coming through are quite high. So Epic is definitely, we're quite connected with them and are working closely together on seeing how learnings that others might have and learnings that we might share with them. I really love the fact that one of the benefits is this, this building that communication, being that knowledge translator between the builder and IT world. Oftentimes in the past, in traditional project management, IT projects, things can definitely get lost and add a lot of time. So I appreciate that you've highlighted that point in your slides. We've talked about what builders can do. This is just another visualization of that. There's a lot of different things, activities in the system that can be modified. Builders get the training to modify and impact many of them. However, it's some things are more difficult, more integrated to do than others. So there's a wide range of things and projects builders can get involved with, and that's where that dyad partnership between IT colleagues and other HS Connect Care team members becomes an important item to consider. We've got a number of different things that we engage with our builder community at AHS. One of which is organic, spontaneous, or our other communities are now sharing information about the builder program. We are working on improving this. There will be a continuing attention to growing the builder program and adding touch points to make sure that people can both become aware of what opportunities exist with builder program, they can participate in it, and ultimately become champions, evangelists, and really be engaged with both from the AHS side and the other commitments that they might have. So briefly on roles, right now we've, as I said, we have been championing this from Epic clients' point of view of getting builders involved as early as we can in our journey through implementation. We have established some formal roles, and folks like Dr. Vince Danino, of course, this falls under one of our formal roles. These are individuals who are leaders of the Connect Care builder program. They provide zonal representation. They help address and tackle some larger, bigger strategic projects. And we've been intentionally trying to have representation across all of the different zones in our physician cohort. And we also have representation in our non-physician, our clinician informaticists as well. And that these folks are representing other areas, lab, pharmacy, nursing, informatics, and align with our clinical operation folks. The far larger cohort, the more interesting one, and the one that I think there's a lot of untapped potential here, and one that has been helped to grow through the Alberta Sport Support Unit. So I just want to make a shout out here as well for AB Sport in helping some folks go to Verona, complete the training, and become certified builders. So we've got a large number of these folks, 64 individuals. So these are individuals who've done training, they are certified, they are able to build. They've met all the requirements from an AHS point of view to be able to build in a system and have the right type of access. And they're now starting to get involved in build activities through some of the workflows we've established. And as you can see, there's some different streams of builders that are available. And everything from analytics to some specialty specific tools as well. And lastly, our builder advisors. So these are folks, 100 people at this point now, who have at least taken the introductory course. These are our change agents. They might have done the course as a way to help understand the system better, to help them introduce it to their colleagues as we're going through the different waves. And that number, of course, is another number, that big number that we can look at converting into these certified builders who can make customizations within the system. Doing a quick time check, I'll talk about the governance structure now, just before I jump into that. So as a builder community, we have established some opportunities to get involved, because we can't have customization happening in the system without any sort of oversight. So we want to make sure that we're aligning to existing Connect Care principles, existing Connect Care governance groups, area councils, formal committees, to ensure that any requests and projects that we do are done so in a provincial manner, or if they need to be local, that appropriate clinical oversight is there. So what we've done is we've created based on Scrum methodologies, a working group of sorts that meets multiple times a month, allows interested builders to interact with other team members who have a role to play in our system customization, including our IT colleagues, our clinical content experts, our clinical system design experts, and bring everybody together in one group and look at the different available existing requests that builders might be interested in taking on and contributing to the system, practicing their skills, or introducing new ideas and new builds for folks to tackle. And it provides a one-stop shop to initiate what sometimes seems like a complex process of getting an idea into a formally approved, vetted item that somebody can actually work on and take it into all the way from that sandbox, proof of concept, and into a production environment. So that is now something that's established. It's available for interested builders to participate in, and those who aren't online who might be certified, please feel free to reach out on the email that I'll show at the end if you have questions on how you can get involved. And those who aren't interested, who aren't certified yet, we'll use that same email for getting more information. So governance, we focus on ensuring that we've got the right committee set up to set the right guardrails for the builder program. As builders, as you come into the system, how do you do your work? We focused on advocacy, and now we're also expanding our community presence and helping groups like this and others to grow the interest and ability to participate in the builder program. Our main concept of the governance structure is that we want to ensure that there's high autonomy of our builders and high alignment to some of the organizational needs that we have in AHS and Connect Care. But we don't certainly want to ensure that there's freedom to do things one way, a specific way folks might have in mind. And maybe I'll finish off on this slide just to give an idea of where things fit in with Clinical Builder. So Clinical Builder formally does report into the Connect Care Content and Standards Committee. So this committee is responsible for a wide range of items within Connect Care. We also have our Clinical Decision Support Committee at the same level reporting into their clinical documentation, clinical improvement support. So it does give you a sense of where Clinical Builder's program fits in and some of the different groups that we work closely with to ensure that whatever we're doing, we're doing so in lockstep and are collectively helping improve the system. And lastly, so as Eddie alluded, virtual training, EPIC has, due to COVID-19, EPIC has, and I keep saying temporarily, likely continue for a little while, it has introduced a way to complete builder training online. The feedback we've received about the courses have been quite positive, and it's highly suggest that if folks are interested, they do reach out and we can provide a bit more information. And then there's some, once you get into our builder stream, you're connected with our groups, there's some other opportunities that we have through our larger community. So on that note, I'll flash up the email address. If you've got any questions, if you're interested in getting involved in the Clinical Builder program, taking some of the training, great place to start is this email address. And Right now, the experience is quite personalized and tailored, so we're definitely there for you to help answer any specific questions and get you involved. So on that note, Eddie, I'll hand it back to you and open it up.
Thanks so much, Pavel. That was amazing and really helpful information on the more specific levels of how to get to more training. So before we open up the Q&A, just leave you with a couple of thoughts. I mean, what Alberta is embarking in is really one of the largest population-based implementations of an EMR around the world. I think only Australia and Denmark might come close. So the potential here for research, practice improvement, and innovation is just limitless almost. And I hopefully have made the case for why builders who bring that clinical research QI lens could be indispensable to this, because it's because they are knowledgeable in what Connect Care has to offer, and then working as a dyad with an analyst will build whatever you need to build to make Connect Care work for you. So I will stop sharing and go over to the panel. We do have one more polling question, but maybe we'll get some insight from our panelists and from others who have joined before we go to that final polling question. So I've got with me Vince Danino, Trina, Nish, Panu. Maybe is there any one of you would like to kind of compliment or add some thoughts before we start taking questions? Or maybe I'll turn this back to Diane for the moderating at this point.
Sure. Thanks so much. I as a facilitator, I was given the opportunity to facilitate this, and I had no idea what it was going to be about, and I'm just fascinated. So we do have one question already in the chat. I'm not sure if Amanda, you have some in the Whova chat, but if you want to start with a question, we can do that. And maybe we'll start with the question, and then as we have a discussion, the panel members can just pitch in and say what they'd like to say about the Builder program, and what's maybe a little bit about what's inspiring you about this. That would be great to hear from the panel. So the question from Laureen Thiessen is, have physician builders working in the analytics stream you mentioned earlier connected with the D&A community?
And sorry, I just need a little clarification on what DNA is. Pavel, do you know?
Oh, data analytics. Okay, there we go.
Yeah, well, I mean,
data and analytics. There you go.
I mean, I could start the conversation. You know, in Calgary, we're on Sunrise Clinical Manager. We work closely with a number of analysts in terms of what Tableau has to offer. We've got a huge suite of dashboards that inform clinical performance, and that we've even used for audit and feedback purposes. So we're speaking the same language, we're on the same page, but you know, it's a great question. I'm not sure to what degree the 24 builders that are certified in analytics have connected with the DNA community that's involved in Connect Care. And Pavel, do you want to pick that up?
Yeah, absolutely. So it is one great question, and it has come up a few times. So I think there's two parts to it. One is that at a governance level, as we move forward, how do we ensure that there's activities happening in our other committees, whether Connect Care related or outside Connect Care and other AHS committees relating to data analytics? How do we ensure that there's some alignment? So intentionally, the membership of our Clinical Builder Program committee does reflect members of our data analytics committee, members of our clinical inquiry and research groups as well, to make sure that as we are identifying these workflows and processes for individuals representing those committees and how to get involved, we're doing so in a way that represents the needs of those unique communities. So specifically to this, if we do have a number of people who are certified in that data analytics stream who might have interest in participating in Builder, in picking up projects, pushing them through. So our focus actually for this year is to reach out to our greater certified community and start pulling folks back into these opportunities, identifying that this Scrum meeting that I had referred to, and getting them involved in activating their projects. To date, a lot of our priorities have been on laying the foundation, creating our committees, creating the right critical mass of builders. And now we're now moving towards enabling people to do this and action some of the ideas that they might have through our working groups, through our Scrum, and through our governance groups. I hope that helps clarify that, Maureen.
Yeah, I think it does a bit. I think that this will probably be explored further as part of the a builder committee that's co-chaired by Bev, and sorry, I can't remember who else was co-chairing that. That builder committee, but I think also as part of that, we're building the analytic builders now, and we're working on building. I think the role has been built, the use cases are going through. So, this will probably surface more and more as we get through those first use cases. And this is really supporting the embedded analysts, right, within the programs that are supporting the clinicians who may not be doing the part of the clinician builder, but supporting those analysts. And then this would also tie, I think, back into our when we take a look at embedding Tableau within Connect Care, and are we going to have different governance processes for those Tableau reports that are created within Connect Care? Are we going to follow a similar one? So, I think all this will probably come out as we start looking at the governance around the builders and those embedded analysts with that analytic builder program.
Yeah, absolutely. So it's a complement of another community of builders that complements our clinical community, our clinical or physician builders. So analysts who might be are involved in this type of work, maybe new to Connect Care or trying to get involved in Connect Care. So that's a good point, and you're right. I think our next agenda is item we'll be looking to tackle that. So great elaboration. Thank you.
Thanks, Pavel. We have a couple of more questions. Trina suggested that maybe Stafford might have some more thoughts about the different role that analytics builders have.
Yeah.
Do you want to
this is Trina. I wasn't aware that Laureen was on the call. She's more, she definitely could also speak to it. Sorry to out you, Stafford, but Laureen or Stafford.
That's okay. I just to add at a high level, it's so exciting that we got this new tool that we could utilize to build analytic products and clinical decision support products and all that. So it's awesome because we never really had that before. With Sunrise and Meditech and Cerner, this is, I think, a big differentiating piece that Epic brings. And so we need to transition away from most of the stuff at least in our analytics world being done out of system because we didn't have these great tools, right? And very limited ability to configure the system. We'd go through the big ticket monster and have to do it that way. So I just see lots of advantages here. Thanks.
Thank you for adding to that. Mari asked a question that I was wondering about too. Who can become a builder? Like, how do you rank or prioritize interested applicants? And really, who is best suited to this? So I don't know who wants to take that question.
I can start. And I might look to Dr. Donino on the call as well, as somebody who has spent a lot of time building and talk about the time commitments. As it's a little bit of how much time do you want to spend away from the keyboard to keep your skills fresh? That's definitely part of it. So as far as ranking interest in applicants, to date, we've been very open to trying to increase the awareness of builder opportunities and to grow our numbers as best we can. There have been a number of different streams to help folks to get trained and become certified. So the funding that I mentioned with Alberta Sports Support Unit, there have been some opportunities from within the CMIO office through formal participation in helping with the Connect Care implementation through a super user role or other training support roles. But really, I think now especially is a really good time to further engage with interested participants, because the main barrier for training has really been the costs associated with the travel and lodging to Epic, and of course your own time commitment to become certified, as it does take 6 full days. So 3 days of 2 courses to become certified. So taking that into consideration, that one of the main barriers from a cost perspective has been essentially removed with this virtual training opportunity, I think that the doors are really wide open for any interested participants, especially on our physician side. When we look about our clinical builders, there is a little bit more nuance just because of the relationships that they have with AHS and some things to consider. And our leads within the clinical world are there to help address those questions and can help redirect. But from a physician builder point of view, as long as people are able to make that time commitment, they reach out to us, and we can get them signed up and trained. Now, as far as so I've gotten trained and I'm a builder. Vince, did you want to maybe speak to some of the time commitments of a builder, whether formal or informal?
Yeah, so of course, you can always get the theory behind the building process, and that even that is, I think, worthwhile taking the courses so that you have a better understanding of the capabilities of the system, so that when you make requests for builds, even you know that right from the start that it's possible or not possible. So even from that perspective, having better understanding of the program itself, taking those courses is great. If you're going to build, of course, there's always a certain amount of practice and to keep up your skills, and so you need to be able to continue and devote a certain amount to that process. I don't have what a minimum amount would be, because of course that would be very individual. But but even if you just take the courses just to understand the back end better is worthwhile.
If I could just add, lately what I do is I record a Zoom call with the analyst who's helping me build, and I bring up Hyperspace, and we work through what I'm supposed to be doing, and I record that, and I find that a really efficient and helpful way to get things done as a builder, even if you are a bit rusty.
Yeah, and to add to that, even Eddie, if you're new and you're picking up some work and you still don't have that confidence, then through the builder program, you can always get tagged with somebody else to work on that build with you, who's a more experienced builder, so that you don't get left alone and say, well, I'm going to pick up that work and I don't know if I'm actually going to be able to complete it. So the builder program and the process that has been established for picking up work, you're not left standing on your own if you don't have that confidence yet. So.
Great. I just want to, for my own purposes, you scratched out physician in physician builder program. Do you have to be a physician to be a builder?
No.
So within the clinical builder committee, and we potentially call it clinical builder, as we were developing and taking it through all the different approving groups, one of the key items that we wanted to establish that we recognize in AHS will likely have different types of communities, whether it's physician, clinician, the non-IT analyst that we were speaking about earlier. So we expect that as these tools get a wider adoption, there'll likely be different communities, and we're there to support all those different communities. The physician route and the clinician route, they are well defined by Epic, so we're able to leverage the classes that they offer. Some of the other internal communities we might stand up, they're a little less defined by Epic, so we'll have to work through our own internal processes to get things supported there. So as far as what's been presented around the Epic training, those are constrained to specific roles, whether it's physician or clinician, and have a few different requirements attached to them. So yes and no to answer that question there.
Thank you. And we only have a few minutes left. Amanda, there is a question still in chat, but were there any questions in the Whova app?
No, there is not.
Okay.
There's just the Zoom chat questions there.
Okay, so Stafford, you're being targeted again. Eddie's suggesting that you might help answer this. In the discussion of patient-centered care, the use of the My Health app was discussed. is the My Health app the same as or connected to the patient portal in Connect Care?
That's a good question. So is the My Health app the Alberta Health patient portal that they rolled out? Yeah, they're not really connected. I think in the background, they're connecting them and trying to put a facade on that kind of makes the same for Albertans. But I can't actually speak to the details of that. Sorry about that.
Yeah, they are two different applications. My AHS Connect was formerly called My Chart. That's what it was called, but we rebranded it in Alberta as My AHS Connect. At the time when we were rolling it out, it was determined that it was redundant to several things within the Government of Alberta application that you're speaking to. So they are working to make sure information flows, but right now they do different things. The My AHS Connect, the Epic patient portal piece, is intended really right now for when you present to an ambulatory clinic, and you're looking to work with that clinic to have a portal that allows you to see appointments that are coming up, some communications with your clinical team, and any sort of results may be released to you through that. But as far as your provincial contact from the Government of Alberta, that is through that Alberta Health app, if that makes any sense.
And Trina, I don't know if you saw Tanya's question. I think she had to step away. But if someone's got an idea for a pragmatic trial that would occur through Connect Care, just like the ITADs, is it premature to ask that to be explored by the CIRWG, or would that be a reasonable way to explore feasibility for a researcher wanting to do this?
So we're getting to the point right now where these are getting to a level of maturity that we can start looking at whether or not this can be provided as a service level. And it's never the point of getting, there are builders out there. Vince has been doing this, and Eddie, you've now been working in the program. We do have builders. The key piece that we need to get to a level of maturity at AHS is how we get these requests, how we ask the right information, and then get them to the builders. So, and that really required us to have an understanding of the builder program and have enough builders, and we're there now. So now we're playing catch up to make sure that we can offer this. We don't want to offer this just to anyone who comes through the door. We want to make sure we're taking a very well thought out approach to this and getting it to the people who need it. And so the answer is it's coming and it's coming in between the waves. So the reason why we don't have it already is, of course, we have these 9 waves of implementation that is offering the foundation level of service. And then these things where we go after things that we want to have beyond the foundation, we have to do in between the waves because there's only so many of us. So yes, it's coming. Yes, I think we can explore it. How quickly we can offer it is the question.
Great answer, Trina. We're at 1 o'clock, so we should wrap up. I want to say thank you to Dr. Lang and all your friends. What a great idea to invite your friends to help you answer these questions. I can hear the passion, and it's. I think everyone enjoyed the session. They stayed till the very end. So thank you so much again for being a part of our virtual institute. And just want to remind everyone, we have another session. I believe Trina, you're presenting tomorrow. Do you want to tell us the topic of your presentation tomorrow?
Yeah, so I'll be speaking at lunch, same time tomorrow, and it's on digitizing health and research. So it's the ability to integrate research into care and looking more at that research module, not just the build components, but what is the module within Connect Care intended to do, and how do we bring in individuals that want their research study to be connected to the patient record. So Christy McLeod will be there with me to speak about the administrative aspects, and I'll be speaking about the integration. Thanks very much. Hope to see you guys tomorrow.
Great plug. Thank you again.
Thanks for sharing, Diane.
All right. Bye. Thank you, Amanda.
Bye, everybody.